that the prostate gland is the only extra organ in the male lower urinary tract compared to the female lower urinary tract. Other than that, we are very concerned with the internal urethral sphincter and the external urethral sphincter, which is the main control mechanism for urine control. Incontinence has been classified into various types. Most common ones are the stress urinary incontinence, urgency urinary incontinence, mixed urinary incontinence, and overflow urinary incontinence. Briefly to tell about each, in stress urinary incontinence, as the word name suggests, whenever there is any increase in stress or pressure inside the abdominal cavity that is translated directly to the bladder, which results in leakage of urine, maybe a few drops to large quantities. What is the etiology? As you can see in the image, the external urethral sphincter, when it becomes weaker, it can't provide the required support for the bladder. And this loss of support results in leakage of urine with any increase in the intra-abdominal pressure. Urgency urinary incontinence, as the word suggests, is involuntary leakage of urine which is accompanied by or immediately preceded by a severe urgency or need to want to pass urine. So it can either present as a part of overactive bladder syndrome or can be a presenting complaint for a neurogenic bladder. When you have both stress and urgency together, we name it as mixed urinary incontinence. And overflow urinary incontinence, as the name suggests, is when the bladder is overfull, not able to hold any more urine, and then it starts leaking or overflowing from the bladder. In addition, we have something called as continuous urinary incontinence. I'm not going to talk about this at all because this is again a large topic by itself. It can be congenital, as in ectopic ureters, or acquired when you have a vesicovaginal fistula or a ureterovaginal fistula as a complication due to some other surgeries. Diagnosis and treatment, very importantly, here is the need for a detailed history, physical examination, and very important to maintain is a bladder diary, which is very required so that you know exactly what is the severity of leakage and what is the level of botherness. Because unless it is bothersome, patients are not ready to undergo treatment. They are willing for probably lifestyle modifications, but going beyond that depends only upon what is the botherness of the symptoms to that particular person. Investigations, as a urologist, two most important ones are USG, KUB, PVR, and Uroflow. These are the basic essential investigations which we need to see if the person is emptying the bladder well or not. And for most of the index cases of urinary incontinence, these are sufficient. We don't need any hi-fi investigations. If we have patients who have associated anatomical problems like pelvic organ prolapse or a recurrent urinary tract infection, recurrent urinary tract infections or recurrent failure of previous surgery and there's a recurrence of incontinence or incontinence following radical prostatectomy or TURP, we may do urodynamics or CT and MRI for further evaluation. Very important to stress is not every treatment works for everyone, and you may have to try more than one before you are successful in getting the right treatment for the person. So lifestyle changes, pelvic floor exercises, drugs, this is what we start off with. And if a person is unfit for surgery or unwilling for surgery and has failed these methods of treatment is when we decide that we want to do medical devices, whereas you can use pessaries or urethral plugs. So this is a non-surgical arm of the treatment, which we begin with for most of the patients who approach us in the outpatient department. Kegels exercises are very, very important and need to be taught and emphasized upon for all of them because, as I said, the external urethral sphincter, the pelvic muscle tone is what is important. And you need both slow and fast Kegels exercises because you want to have the constant muscle activity to hold the urine when the urine is being stored, and whenever there's a sudden rise in abdominal pressure, you want the fast twitch muscles to suddenly contract and give an additional support whenever there's an increase in the intra-abdominal pressure. So slow Kegels exercises and fast Kegels exercises are directed at developing both the muscles, the fast and the slow muscles of the pelvic floor, so that you have full continence. When all fails, we have lots more left, that is urethral bulking agents. This is when you inject bulking agents at the bladder neck so as to increase the outflow resistance. So EAU guideline states that this should not be offered to women who want a permanent cure. It is for temporary cure because the benefit diminishes with time, and it may require repeated injections of these agents in the bladder neck area. Anyone who is motivated to have a permanent cure and has a level of botherness for the outflow, for the incontinence, can be counseled towards having bladder neck suspension surgeries or sling surgeries. Bladder neck suspension was the gold standard, started in 1961, but has now given way to sling surgery, which are minimally invasive, just requires very small incision, maybe even just in the urethra itself. But a lot of problems have come up with mesh usage, and UK and Australia have almost given up on using mesh and have moved towards autologous slings, because problems or complications like mesh erosion, chronic pain, dyspareunia, infection has led to litigations, and these have led to a lot of large payouts. So now what we advocate is using something called as autologous facial slings. So we harvest the fascia from the lower abdominal rectus muscle or from the fascia lata, design it to form the same kind of a sling which was given as a mesh, which was being advocated, and use it in this, as seen in this image, through very small incision in the anterior vaginal wall. We create tunnels to put this sling to support the urethra. So anytime a person is willing for surgery, it's very important that the patient is comprehensively counseled about risks of mesh implantation, together with the conservative options and other surgical options, so that the person is willing to accept what are the problems that can come if they arise. We have if that fails, what next? Or in male patients, we have something like artificial urinary sphincters. So this sphincter is placed in the urethra, and you have a reservoir of fluid which is placed in the lower abdomen, and there's an activating switch which is pump, which is hand controlled in the labia majora or the scrotum, which you can press to deactivate the sphincter. The water comes back into the reservoir and they can void, and once they finish voiding, they can reactivate the sphincter, which fills the fluid back into the band around the urethra, which closes the urethra. Very good for especially post-prostatectomy, radical prostatectomy urinary incontinence, or women who have urogenic bladder causing urinary incontinence, or in recurrent incontinence after surgical failures. This is even more advanced, adjustable transobturator male system, ATOMS, and there's a cushion which is placed, and you have silicone tapes which hold it in place against the pubic bones. And you have a similar titanium port for activating and deactivating this cushion, which gives the support to the urethra. The very other side of incontinence, urgency incontinence. Two totally different spectra of incontinence, two totally different treatment modalities. And in this, like in stress, first line is always lifestyle modifications, bladder drill, so that the patient who comes realizes that, okay, I have tried everything and now I need to go one step ahead with the surgical correction, which is the treatment for me. But in urgency, most of them do settle down with non-medical management, because we have very good the pharmacological agents, which are anticholinergics and beta-3 agonist. Anticholinergic, many a times patient discontinue because of the side effects, dry mouth, constipation. This is the limitation. But with beta-3 agonist, there are less of these side effects. We have to be more cautious only with hypertensives, because they can have a hypertensive crisis, which also is not is less than 1.5 to 1%, not more than that as the rate of complication. If lifestyle modifications and pharmacological agents are not successful, we have three options left with us, which are not very commonly used but are available. One is Botox, which can be done as an OPD procedure. You just require a flexible cystoscope with local anesthesia. You can inject onabotulinum toxin A in the sites as shown in this image. And this is not permanent. You need to keep repeating as the effect wears off. The only thing that you need to counsel is that because of this, they may need self-catheterization, CIC, if they are not able to void and the bladder becomes too relaxed. But we can be a very good option to people who are not getting relief with anticholinergics. The next one is sacral neuromodulation, wherein you can place an electrode at the S3 level of the spine, which can suppress the reflexes which are responsible for involuntary retractor contractions. So this is can be the electrode is placed in there. It is a small one, so you don't have to have a bulky machine or anything outside. And third is pocketness tibial nerve stimulation. Very simple, as you can see, the person is sitting comfortably in chair and you're just stimulating the peripheral nerve, that is a posterior tibial nerve, which then stimulates the sacral plexus and causes suppression of the contraction of the detrusor. Just to briefly summarize, most commons, both of them, I'm sorry, the image is a little too small and blurred, but what is important to stress upon is that you first start off with lifestyle modifications, then come from there to pharmacotherapy. If pharmacotherapy doesn't fail, then you need to counsel them towards the more invasive forms of treatment. And it is, there are various options available. You just need to explore them before telling somebody that they need to live with incontinence. For patients, just give up and say you can live with pads and diapers all their life. Thank you.